Hi everyone, what? Stop that. Hi there everyone, my name's Ollie. I'm a third year medical student on the graduate entry programme at Warwick Medical School. So as of today, when this video goes live, having just completed 6 weeks of surgery. So I thought this video would just be a good chance to go over some of the things that I've seen, some of my highlights from the past month and a half from my specialty surgical block, because that's all the general surgery and urology teaching I will have before finals, which is a terrifying prospect. So just a brief catch up for those who don't know, I'm now into phase 3 of the course at Warwick Medical School, which starts in year 3 and runs all the way through year 3 and year 4, and then we sit finals in about a year's time. In fact, it is exactly a year's time as of when this video goes live. And phase 3 is split into 8 6-week long specialty blocks where you see a variety of things like surgery, general medicine, acute medicine, pediatrics, so on and so forth. So that's SCP-1, surgery for me now over. We all start on different things and rotate every 6 weeks. So different people in the year are doing different things. But I've started with surgery, and that actually means that I have general medicine as my last block, which is probably quite a good time to have it just before exams. But here we are, so this video is about surgery. So we were given 2 consultants, who are our named consultants for the block. We had 1 colorectal surgeon and 1 urologist. So we spent most of our time with the general surgeons and that team. So we saw lots of things, you see lots of the standard things like laparoscopic cholecystectomies, appendicectomy, colectomy, formation of stomas, things like that. The really common things that people come up with. Acute pancreatitis, intestinal obstruction. And it was a really good chance just to cement the learning that we did last year, as well as build and learn some new things in preparation for finals. Just as a quick reference, phase 1 is the basic sciences year, so year 1 where you do all the standard anatomy, physiology, basic pathology. Second year is much more about forming a diagnosis, so using signs, symptoms in conjunction with the knowledge that you already have to determine what's actually wrong with someone, and very, very basic management of what you would do, whether that's things like give antibiotics, do fluid resus, this kind of thing. Phase 3 is now taking everything that we've done so far, because remember, most medical schools, or at least the majority, operate on a spiral curriculum. So you revisit the same content every year and renew it. And now in phase 3, it's more about management. So being able to accurately spot the diagnosis and make sure that nothing kind of dangerous is going on, and then knowing exactly what you would do. So if you say give antibiotics, what antibiotic? Maybe if they're allergic to penicillin, what are you going to give then? Or if it needs to be surgically managed, what surgery are you going to do? What are the risks and complications that come with that surgery? And being able to explain any procedure to a patient in preparation for OSLAs, which are a unique feature of phase 3. So in phase 1 and phase 2, you only have OSCEs, objective structured clinical examinations. So you basically have 5 or 6 minutes in a room, and you might be asked to perform an abdominal exam on this patient, test this patient's blood sugar and explain the results to them, or do a urine dipstick for this patient. So phase 3 introduces OSLAs, which are long cases. I think they're 15 minutes. So you have to take a history, perform an appropriate examination, request any blood tests or anything that you want. For imaging, the marker will then give all the relevant information to you, and then they basically grill you on the management of the patient. So what's wrong with them? What are your top 3 differentials? Why do you think it's this and not this? And then they can ask you lots of questions about the anatomy, physiology, pharmacology of whatever condition it is that the patient has. Basically, it's preparing you for the level of knowledge and the sorts of consultation that we'll be doing as foundation year 1 doctors, and just trying to make sure that we are safe before we get released into the real world where we will actually be managing patients. So what's made this block really good? It was really well organised, actually. Props to the team at South Warwickshire Foundation Trust, which is where I've been for this past 6 weeks. It's always been pretty clear what we're meant to be doing and when. If we have scheduled teaching or whatever, rearrangements have been minimal and everything's kind of gone as planned, which is difficult to do within the NHS when things are in constant flux. Our consultants have always been pretty keen for us to scrub in. I want to do surgery, so any chance to scrub in and maximise my experience is always really good. helps build out my portfolio. My clinical partner, Jodie, isn't too fussed about surgery, but I've tried to make a conscious effort to have us alternate. If I was by myself, I'd preferably be scrubbed in 100% of the time, but actually being scrubbed is a really good learning opportunity. So it's important that we all have that, I think, whether or not you're actually interested in surgery. And in those cases, I'll either, watch as best I can from elsewhere or go and chat to the anaesthetist. And anaesthetists, particularly those that are ITU doctors as well, they're basically some of the cleverest, most knowledgeable doctors that you will ever come across as a medical student and as a doctor, because they have to know all the respiratory, physiology, cardiac, neuro, like all of it, whereas obviously a surgeon, by contrast, is much more concerned with the anatomy. So you can really see both bits. And actually, I was a bit concerned about whether or not I can do this, but I think in the context of the praise that I'm about to give, I don't think this is a problem. So consultant colorectal surgeon, Mr. Martin Osborne, absolutely wonderful teacher. He actually set aside his own time for ward teaching with me and Jodie for several hours at a time, just doing essentially back-to-back OSLAs, which most people don't want to do because they take up so much time in preparation. But it means that we got so much more practice at taking focused histories and doing proper examinations the way that a finals marker would want you to do it than we would have otherwise. We also spent a day with Dr. Zaki Gabala, who is an anaesthetist at this trust. Again, just such a friendly, incredibly knowledgeable bloke. Was always just with us, come anytime you want, just come and we'll do a day of anaesthetics. And we learned just an incredible amount in that one day, and we were able to actually take part in a lot of the stuff that went on that day. And that's something that goes for both of these physicians actually, which is that when we were with them, we very much felt part of the team. And that's difficult, I think, for senior doctors to do, often because as medical students, we have very few useful skills. We are a drag on resources because we need teaching and can't do much ourselves. But, when we were seeing patients, they would always refer to us as on the ward round or whatever, these are my team, including everyone. And it's just a tiny thing, but it makes such a huge difference to how good you feel about what you're doing, and you actually feel valued. So it's a really friendly, helpful environment. And then the third guy, Dr. John Curtis, who I think is a core surgical trainee, he may have finished his training, did one of the best ENT teaching afternoons I've ever had. We went down to A&E, got to actually assist with what was going on there, and then he gave us some fantastic demonstrations using the ENT microscope, so we got to look down each other's ears properly. He suctioned my ears for me because I'm one of those people that has a problem with waxy ears and it affects my hearing sometimes, so I got that for free as a private procedure, so that was cool. And then he let us naso-endoscope, I suppose, or rather he inserted it, and then we had to kind of pilot it down the back of his throat, which is nerve-wracking, but an amazing learning experience that not that many people would be happy to do. So wishing him all the best with his specialty applications. What didn't go so well? Getting our sign-offs for this block was a bit rough, and we were running around one day trying to get certain things signed off. Warwick stipulates that during each block you have to be signed off on a case-based discussion, a mini KEX, which is kind of a short clinical activity like doing an exam or taking a history, and then an OSLA. But the problem is that they stipulate that this has to be done with a doctor of ST3 level, specialty training 3, so they have to be a registrar or higher. And I can see why they make it that way. It's because obviously a doctor needs to be of suitable kind of seniority, I suppose, to make sure you're going in the right direction. But that also creates a problem where those people are exactly the people who are too busy to spend much time with you by definition. And I genuinely think we spoke to every member of the surgical faculty on this Thursday trying to get our sign-offs, and just no one would sit down and do it with us. Then we got very lucky where one of the registrars who had taught us for one of the sessions was able to very quickly sign off our case-based stuff, and then again Mr. Osborne was able to save us at the last minute and do some case-based discussions with us. So again, absolute heroes just coming through and saving us at the last moment. What do I recommend to get the most out of surgery block? Go in early, go in for the ward rounds, and make sure you try and see as many of the presentations as you can and examine as many as you can. Maybe the most valuable thing that we did this block was asking our consultant to do an exam as they would do it from start to finish. Can you do an example of how you would take a history and how you would examine a patient, because then that gives you a baseline to emulate, because that is all we're doing, you know, we're emulating. And then not only obviously does that show that you're interested and you're actively trying to learn from them, it does make you a hell of a lot better at doing what you're doing. And I think there was such a stark difference, particularly when I was watching Jodie, and Jodie was better at this than me when we started. You know, when she was doing it, I was stood watching her, and it's like, yeah, she looks like a surgeon. She looks like she knows what she's doing. It's such a big thing, and it's really shaped how I'm going to approach the blocks moving forward. So thanks very much for watching, guys. That's where I'm going to end it. If you've got any questions about how the blocks work, how I got on with surgery, or anything else, please just let me know in the comments. I always love to hear from you. And as always, if you've got video suggestions or things you would like to hear more about, please let me know. Thanks for watching, guys. There are 3 ways you can support the channel if you so wish. The first is to like, comment, subscribe, share with a friend. The second is you can buy me a coffee through my Ko-Fi link in the description below. And the third is using my referral link in the description to save 10% off your first year's subscription to Complete Anatomy 2020, my favourite 3D anatomy tool. I'll get a small kickback if you do. Take care, guys, and I'll see you next time.